Stevenson, here to introduce the Minneapolis Heart Institute Foundation Grand Rounds. I'd like to thank our exhibitors, Edwards Life Sciences and Novartis Pharmaceuticals, for their support. I'm pleased to present Dr. Roopa Patel and Dr. Alexandra Schmidt give us a talk today on AI in medicine. Dr. Patel is our second-year fellow. They're both our second-year fellows, sorry. And she completed her general surgery training at Henry Ford Jackson Hospital in Jackson, Michigan. And next year, she is going to be leaving us for sunny Eugene, Oregon. And then Dr. Schmidt, is our second-year graduating fellow. She completed her general surgery residency at Temple University. And even though I think I always thought Roopa and Alex got along, they're trying to go to the opposite sides of the country. As she'll be in Philadelphia after fellowship. And with that, I'm happy to introduce them.
Thank you, Dr. Stevenson, for that introduction. So the title of our talk today is Overhyped or Undervalued, Exploring AI in Medicine. We have no disclosures or conflicts of interest. Our 3 learning objectives are shown here. First, we'll introduce the fundamental concepts needed to understand the use of generative AI in healthcare, and then we'll move on to discuss how generative AI tools can be used for clinical documentation and patient communication. And to end, we'll more broadly discuss potential AI applications in vascular surgery. So first, we'll begin by just defining some key terms. A general definition of artificial intelligence could be described as the ability of machines and computer systems to perform tasks that typically require human intelligence, such as learning, problem solving, and decision making. Neural networks are multi-layered systems that mimic the human brain structure and can extract features and identify complex patterns for training data. Generative AI, in general, refers to a type of neural network with a specific architecture and algorithms that can create new content, including text, code, audio, images, and videos. Large language models, such as GPT, which stands for Generative Pre-trained Transformer, this is what powers ChatGPT, which is a type of generative AI and large language model that many of you may be familiar with or have heard of. So let's unpack why generative AI has dominated the news cycle for the last few years. It really comes down to a few major factors that have come together. First, the internet has now been around for over 30 years, so there's a lot of data available that wasn't available for processing and training algorithms during the 20th century. Importantly, GPUs, or graphics processing units, which are the chips that power large language models, have made incredible advancements over the last 20 years. This is crucial because modern models are trained on incredible amounts of data. And even with modern processors, it can still take weeks or more to train very large models. So without these powerful chips, the timescale would be too great to train the models. And then finally, the significance of this paper by Viswani et al. From Google in 2017 that introduced the transformer architecture, which is the architecture on which all of the big generative AI models are built. And this paper now has over 174,000 citations. Oops. So this was the backdrop for these advancements. And then in November 2022, OpenAI did something kind of crazy and released for free ChatGPT. And this led to remarkable uptake by users, making it one of the fastest growing companies in history, as you can see here in this chart, which shows the time to reach 100 million users. So now we'll talk briefly about how the models are trained and function. So training is divided into 2 phases. Initially, the models are exposed to lots of data, often billions of internet web pages, like Reddit, Wikipedia, etc. The models at this point basically learn the usual statistical relationship of words. For example, what words tend to go together or what words tend to follow other words, kind of how we communicate. After learning these associations, The individual companies building the models get humans involved, and they help refine the model's responses to inputs. And their goal is to make these models more helpful, honest, and harmless. And this part is basically proprietary, so we don't know exactly what the companies are doing. So the process that ChatGPT or a large language model uses to generate text isn't that different from how our phones do so when predicting the next word in a sentence. But this kind of undersells it. And so basically these models have been exposed to enormous amounts of data and text, and so they know what words tend to come up in a sequence after other words. So if ChatGPT gets the input, the best thing about AI is its ability to. It's seen text like this many times before, and so it knows that the next most common word is learn, so it puts in learn. And then now it has a new string of text, and so now following learn, it thinks the next most common word is from, and so on. But if it just did this, the text would kind of fall pretty flat and not be that interesting. So instead, at random intervals, it will put in a less common piece of text. And this is called the temperature of the model. This is important because by doing this, it makes the text more interesting, creative, and helpful. But it also makes it so that if you put the exact same question into a large language model like ChatGPT, it will give somewhat different answers each time. And this is really important to recognize when looking at studies, because if we get some results from how a large language model performs, we need to realize that even in the same moment in time, it might generate different outputs if re-entered, making it difficult to reproduce a study. Not only is there variability in responses in the moment, but over time, the performance of the algorithms also changes, and this is what's called model drift. So in this paper above, they had tested the exact same model of ChatGPT, which was GPT-4 in March, and then again in June of 2023 on standardized tests. For these graphs, the better performance is out towards the periphery. And you can see that in March, which is in blue, the model did much better on many of the assessments than it did in June. And it also didn't follow instructions as much in June compared to March. And this is because the proprietary algorithms are often being updated or changed by the companies. And so this just presents kind of an additional concern where, if you see evidence of a good performance from a randomized control study using a large language model or generative AI, you can't really be sure that it'll perform the same for you at a later point in time, especially if it's using a proprietary algorithm that's changing or being updated by the company. So there have been hundreds of editorials talking about how large language models like ChatGPT are going to revolutionize medical education, clinical decision support, and how we interact with patients. But with that being said, I wanted to focus on talking about how the technology is being used now in 2025. And so 3 widely discussed examples of clinical applications are shown here. The use of generative AI to draft patient messages from provider inboxes, the use of ambient scribes to automate medical documentation, and the use of open evidence to evaluate clinical questions based on available literature. So to get into the first of the 3 examples, which is drafting of patient inbox messages, large language models can help address patient portal messaging, which has seen over 150% increase during the COVID-19 pandemic compared with pre-pandemic levels. This rapidly growing modality for care has strained providers and become a leading factor in clinician burnout. And so as you can see on the screen, the basic idea is patient inbox messages would get routed to a large language model, which would draft a potential reply from the clinician. The clinician then would receive the draft and could either edit the draft or just start from scratch. So this was a research study from Stanford assessing the rollout of patient inbox message drafting using GPT in this hospital's primary care and GI and hepatology clinics. They looked at a primary outcome of AI-generated draft reply utilization with secondary outcomes evaluating time, usability, utility, and impact on clinician well-being. Pre-surveys and post-surveys were distributed to all clinicians to look at the electronic health record burden, which was evaluated using a 4-item physician task load score derivative, with scores ranging from 0 to 100 and lower scores indicating less cognitive task load. Burnout was also evaluated using a 4-item questionnaire evaluating work exhaustion score, with lower scores, again, indicating lower levels of work exhaustion. The third thing the study looked at was clinician satisfaction with the tool, which was assessed using the Net Promoter Score. The Net Promoter Score is calculated by asking the questions, how likely are you to recommend this tool to other clinicians on a 0 to 10 scale, where 10 is most likely and 0 is least likely to recommend. Respondents are classified as detractors, passives, or promoters based on the score that they give. And then the Net Promoter Score is calculated by subtracting the percentage of respondents that are detractors from those that are promoters. The Net Promoter Score ranges from -100 to +100, with higher scores indicating more satisfaction. But any positive score, so anything above 0, is considered a good score. The researchers used the electronic health record event logs to track the time clinicians spend on specific actions related to inbox messages, primarily focusing on reading and writing time. They compared the time spent during the pre-pilot period, which was the 4 weeks leading up to the introduction of the AI tool, and the pilot period where the AI draft tool was available. Overall, there was no statistically significant difference in the average time clinicians spent reading messages or writing replies between the pre-pilot and pilot period. So overall, 80% of messages were replied to. Only 59% had a draft available for use because messages with non-English language, an attachment present, or messages sent by a proxy were excluded. Clinicians used the AI-generated drafts for about 20% of their replies on average. In terms of clinician well-being, there were statistically significant reductions in clinician-reported task load and work exhaustion scores during the pilot period, suggesting this AI tool helped lessen burden and burnout. You can see there was a lot of variability in the Net Promoter Score among different groups, but overall it was positive with a score of +10. You can see the primary care physician and APP group had a positive score of 13, whereas the GI and hepatology physician and APP group had a score of -19. So there does appear to be some specialty-dependent responses. This study did identify that there were differences in satisfaction as measured by the Net Promoter Score, but it really didn't delve into the underlying causes for this variation within the discussion presented. So while direct evidence for application of patient draft replies in surgery clinics is somewhat limited, it's at least helpful to extrapolate from this study to decide whether these tools could be implemented widely in surgical fields. The results of this paper suggest that, like any new tool, it would likely be well received by some individuals and poorly received by others. A word of caution may be given in that GI is a procedural specialty, so the fact that the APP physician group had a Net Promoter Score that was negative might suggest less utility in surgical clinics compared to the primary care group. But overall, I think it would be reasonable to trial, but it should be noted these tools are often sold on a per provider model, usually a few $100s per month, or even in Epic, I think for like the full generative AI suite, it can be up to like $1 million for the hospital per year. So they're not necessarily the most inexpensive. So close monitoring of efficiency and provider reception would be important for implementing this type of tool. So now we'll talk about the second way large language models are being used. An ambient scribe is an AI program that automatically captures and transcribes patient-physician conversations during clinical encounters. It sifts through chit-chat, generating structured medical notes that can be then edited and finalized by the healthcare provider. The aim of this study was to evaluate the association between ambient voice technology coupled with natural language processing and AI on primary care provider documentation burden and burnout. This was an observational study involving 110 primary care providers working at the University of Michigan Health West. The primary objectives were to determine the association between DAX usage, which is the ambient scribe, and provider burnout scores on the Oldenburg Burnout Inventory, or OLBI, and the effect on documentation time per patient encounter. The completion rate for the survey was 75%, and approximately half of the responders were physicians and the other half APPs. High DAX use was defined as, in over 60% of encounters, was seen in 28% of providers. OLBI is made up of two subscores, disengagement, OLBI-D, and exhaustion, OLBI-E. OLBI-D, disengagement, measures the ability to distance oneself from work and work-related negative attitudes and behaviors, while OLBI-E, exhaustion, measures feelings of physical fatigue and overload related to work. Each subscore consists of 8 Likert questions with a total score, OLBI-T, that ranges from 16 to 64. Higher scores indicate more burnout. Overall, as you can see, the group has some burnout, but it was considered low, where in this study, low was considered to be less than 44. It's important to note that there were no OLBI scores pre-implementation of DAX, so these are all after the fact. You can see between high and low DAX users, there is less disengagement burnout among the high DAX users, and so the implication of the paper is that maybe the use of DAX reduces disengagement burnout, but it's also very possible that the high DAX users, of course, are just more engaged clinicians who would be more excited to use a new technology. But a more interesting part of the paper is how they did have pre and post documentation metrics. So average documentation time per note in the pre-implementation period was 5.9 minutes. After DAX implementation, the average documentation time per encounter was significantly reduced by 28.8%, and the time documenting outside of scheduled work hours was significantly reduced by 11.8%. Percent contribution to the note by provider decreased by 33%, and documentation length was increased by an average of 542 characters. As you can see in this table, the authors did report the differences between pre and post DAX, but did not report the absolute numbers. And so, while this study review doesn't convincingly say that provider burnout is improved with the use of ambient scribes, the fact that providers spent less time actively documenting patient encounters but generated longer, potentially more detailed and helpful notes is encouraging. So while there's limited research trialing the use of ambient scribes, especially in the surgery clinic, it would be something that could be reasonable to test out. But once again, this type of tool generally costs up to several $100s per provider per month. So monitoring utilization and documentation behavior would be important. So lastly, I just wanted to quickly discuss Open Evidence. Open Evidence is a free AI platform designed for medical providers that synthesizes evidence-based insights from a vast database of over 35 million peer-reviewed medical articles. It should be noted that it generally uses abstracts as a source of data, but it has access to the full text of all New England Journal of Medicine articles based on recent partnership with them. It works by allowing users to ask natural language medical questions and then provides answers with citations to help inform clinical decision-making. I'm not aware of any clinical studies evaluating Open Evidence, but it has had significant uptake among providers, so I just wanted to show a quick demonstration. So I've basically entered a pretty straightforward question related to vascular surgery. Should a 73-year-old male with a 5.7 centimeter abdominal aortic aneurysm undergo operative repair? And so then basically you can see it's kind of thinking for a moment, and then it starts giving an answer here. And it, basically says yes, that based on current recommendations, because of the risk of rupture, that this patient should be someone considered for operative repair. And basically it kind of briefly talks about the guidelines to support this. Lower down, you'll see that it brings in a table from a New England Journal of Medicine article where it lists the rupture risk, based on size. And then it briefly also talks about, endovascular versus open repair. And it doesn't delve super deep into when to do one or the other, but just kind of broadly says, based on their operative risk and anatomy, things like that to consider when selecting a repair. And then here at the bottom, it lists multiple papers that you can refer to. And then it also has some follow-up questions that you could consider asking the model. One thing that is important to just consider, these models or large language models in general can make up answers. So you do just want to be cognizant of that and basically refer directly to the source material as well to kind of confirm that what you're reading is true and that these sources are coming from where they say they're coming. But I would encourage everyone to kind of try open evidence because it's pretty neat and can be really helpful for answering a lot of clinical questions. You can also ask it to write patient instructions or home care, things like that. So it's pretty helpful for, I think, all providers. So, and now I'll hand things over to Roopa to continue.
Whoops. Okay, so I'm going to move on to applications in vascular surgery. So why is vascular surgery ideal for AI integration? It's highly suitable for machine learning applications for several reasons. First, the endovascular revolution has made vascular surgery a field that's oriented toward technology, medical imaging, and facilitating the application of powerful machine learning. Secondly, there's objective clinical data and definitions for vascular conditions, such as the size criteria for abdominal aortic aneurysms and peripheral vascular disease with defined ABI. This allows the algorithms in machine learning to automate diagnosis with little human input. Thirdly, vascular surgical procedures are often high risk in patients with multiple comorbidities. So it's critical from our standpoint to make accurate preoperative risk stratification for outcomes in the postoperative period. All of this is necessitated by the availability of data. With a growing abundance of databases available, such as the Vascular Quality Initiative here in the US, and then the European SVS VascuNet, there's larger databases that are available to capture this data to create algorithms to predict these outcomes. With respect to the care of surgical patients, AI and machine learning have shown utility in applications ranging from image quality segmentation, triage, and postoperative prognosis. In vascular surgery specifically, there has been an exponential growth in the body of literature describing AI and machine learning, especially with a focus on carotid disease as well as aortic disease. So before we start going into the applications, I think it's important for us to understand exactly what algorithms are being used to develop this information. So machine learning is a subset of artificial intelligence, with deep learning being a subset of machine learning. Machine learning is usually divided into three different types: supervised, unsupervised, and reinforcement. Supervised machine learning uses labeled data with independent and dependent variables to help figure out a connection between them to correspond with the outcomes that happen. This is then applied to new patient sets to predict outcomes. Unsupervised machine learning explores patterns with unlabeled data sets using independent variables without any prior knowledge of outcomes. This learning method can uncover unknown relationships within data sets to help predict further outcomes. And then reinforcement machine learning uses trial and error, tasks coupled with rewards and penalties to increase chances of desired outcomes. This machine learning doesn't use any labeled data sets and uses trial and error to come up with an algorithm to train the algorithm for evaluation. So this could be used, for example, in patients who are undergoing EVAR, who've had complications. The reinforcement will evaluate the patient outcomes and try to figure out patient behaviors that may have proposed or complicated the situation. These behaviors are then applied to the pre-op patient to see if they're higher risk for certain outcomes. Now, deep learning, a subset of machine learning, can be divided into these three main types of neural networks: artificial, recurrent, and convolutional. These are just ways that the system kind of figures out what your input and your output are through hidden layers. So artificial neural networks are feed forward. It's only one way. You have input, you have hidden layers, then you have an output. Recurrent neural networks can use the data that it finds and then apply it to the next set within the same system. Convolutional neural networks is used to process data in a grid-like structure. This is most likely to be applicable to image-specific specialties, especially like vascular surgery, for evaluation of imaging. The convolutional neural network creates and processes through a grid-like structure to create imaging that then allows the algorithm to learn features that can be used to make predictions in the future. So how is this applied to vascular surgery? This figure here shows how AI is already becoming integrated into the preoperative, intraoperative, and postoperative aspects of patient care. All of the green boxes here are AI algorithms that are currently being developed to help in management of these patients. So early research has shown AI applications with image evolution, diagnosis, and risk stratification based on aortic morphology. Viz.AI is one of the FDA-approved algorithms that analyzes imaging modality with clinical parameter data to search for vascular disease. This is actually an application that you can have on your phone and input patient data in a HIPAA-compliant manner. The Viz.AI will review the patient parameters as well as imaging, and then notify the operator, the clinician, of any vascular pathology that may come up. This allows the provider to coordinate care in a HIPAA-compliant manner at their fingertips. This Viz.AI is also approved for other aortic pathologies and to evaluate right and left ventricular strain or heart strain and PE. This has shown to decrease time of diagnosis and improve time to treatment. AI can also be used for risk prediction. Different AI programs are being created to analyze aneurysm sac regression or sac size following intervention, which then can be used to develop algorithms to predict how the geometry and flow rate and flow measure through the aneurysm can affect its growth rate in surveillance, to kind of individualize patient surveillance as opposed to just globally following up everyone in a year. In terms of surgical planning, there are many emerging software developers that are being used for preoperative planning and intraoperative uses. One of the current softwares we have here, 3Mentio or Centerline, uses AI to take a 2D image via CT, make a 3D model for us to plan for our aortic procedures. There are also companies that are promoting intraoperative use for navigation, two listed here: intraoperative positioning system and Philips fiber optic RealShape. Intraoperative positioning systems uses a navigation-based method where you put a registration pad on the bed. It's hooked up to a computer system. Using their guide wires and catheters, you can map your navigation based off of the imaging to decrease your fluoroscopy and radiation exposure, as well as contrast use. The Philips fiber optic RealShape is another method for similar use. This uses an overlay on the imaging we already have and can be used with the Philips II system. The fiber optic RealShape is integrated into some of the newer models for Philips, and this allows you to have an overlay on the fluoroscopy image to, again, reduce your radiation exposure and your contrast use. What's different about these two is that the fiber optic RealShape allows you to use the catheters you're familiar with by using a hub on the back of that catheter and a guide wire that they specifically make to help you navigate. So it's still useful for the surgeon or the operator to have the tools they're comfortable with while using new data. So I think future of AI in aortic surgery, I think we're going to get to a point where they're able to completely map out pathways for vascular care and individualize it based off of clinical and image data. So this was a retrospective study that reviewed cases from 2019 to 2022 in the US and in Europe. And they evaluated the performance of a deep learning application for detecting, classifying, and highlighting suspected aortic dissections based on CTA evaluation. And the goal of this was to evaluate the potential to improve triage times in the clinical setting. So they used a convolutional neural network algorithm for image segmentation. There were 2 radiologists that read all of the images independently and a third to kind of figure out if there were any disagreements. Then the AI software was used to process all of the imaging as well. The inclusion criteria is here listed on the left of the screen. The data was then categorized into type A and type B dissections. Of note, the application was able to identify accurately 94% of patients with aortic dissections and rule out 97% of patients with aortic dissections. When further analyzed, the data was able to, with 100% accuracy, diagnose type A dissections, and with 89% accuracy, diagnose type B dissections. Some of the imaging findings that limited the type B dissections are listed here: intramural hematomas, penetrating aortic ulcers, and artifact. The deep learning system was able to successfully conduct screening, classification, and prioritization by notifying the operator for the presence of aortic dissections. And the time to notification was 28 seconds. So it was very quick in their image evaluation. So like aortic evaluation, carotid disease has been studied in AI pretty extensively to this point, but applications haven't been implemented in the clinical setting. Early applications of AI in carotid disease have been evaluated for image segmentation with the ultrasound or carotid duplexes that most patients get in the surveillance follow-up. The pre-processing imaging for segmentation is usually required for ultrasounds due to their lower quality data and detail in the imaging itself. And so machine learning and deep learning systems have used and found ways to pre-process this data to get you carotid image segmentation. They use normalization, denoising, and image enhancement to pre-process. With time, these machine learnings have been able to be input into deep learning systems with now pre-processed without having any human input in reselecting through the image processing. So you don't have to have any manual feature extraction, then put it into a new algorithm. This all just does it, and then you get the output image, which is the same as the image extraction that was placed with the human interaction. So this has allowed AI and machine learning to figure out, what puts you at higher risk for strokes, or who's going to develop further stenosis quicker than other patients. One thing that we have noticed is that carotid intima media thickness is one marker for increased incidence of risk of stroke, and the deep learning and machine learning have found a way for image segmentation to calculate the score even on duplex imaging to figure out which patients are higher risk. They also have found ways to evaluate plaque segmentation to see plaque surface appearance, density, and volume to eventually predict risk of plaque rupture and stroke. So this was a study that was done from 2010 to 2021, which evaluated about 370 patients who were diagnosed with carotid artery stenosis and had CTA head and neck imaging for evaluation. This software used in this study specifically had previously been used to evaluate CT imaging in patients who had undergone CEA or carotid endarterectomy with plaque sent to pathology for evaluation. Their preoperative imaging was evaluated to assess for calcium volume, plaque hemorrhage, lipid-rich necrotic cores, as well as matrix volume. And then that was then looked at under the histopathologic section, and both of them were noted to have similar input and output from the ex vivo and in vivo trials. They divided the patient population here into 3 different groups. clinical variables only, software plaque morphology only, and then in the third group, clinical and software variables, which of note was noted to be the best predictor for your 30-day risk for mortality and stroke. Some of the significant risk factors are listed here, but the strongest risk factors they found were age greater than 80, COPD, previous stroke, and then on image segmentation, your matrix volume in the highest quartile. This was actually able to individualize your stroke and mortality risk at the 30-day period in different patients. And so this was one of the ones that they were able to individualize. So you can apply this in your preoperative setting to figure out if your patient is higher risk given their preoperative risk factors. So the VALIDATE study, which was the validation of AI to limit delays in acute stroke treatment and evaluation, investigated platforms like Viz.ai, which was that FDA-approved platform that I had previously spoken about, to see if acute care or acute stroke time to triage was decreased and treatment and delays were decreased. So this study split up the patient population into 4 different groups: EMS pre-notification with AI and without AI, and then no EMS pre-notification. About 76 of the facilities had AI capabilities and 90 didn't. This study noted that in the AI groups, the door to neuro IR time was actually 39.5 minutes, and in the non-AI group was 89.5 minutes. So there's a significant difference in the time to treatment between the two. They also looked at the ability for the facility to do thrombectomy, and split those groups up as well into the AI and non-AI groups. And regardless of the capacity of the facility, your time to neuro IR was still significantly shorter in the AI group. So the image processing facilitated earlier treatment times. I think another one here, especially in the training and training now in surgical education, how is AI going to affect this? I think one of the biggest things is personalized training. This helps to evaluate each trainee on an individual basis. We all learn differently. We all work differently. And so this helps to individualize your learning experiences based on deficiencies, and then can provide improves a study guide for you to improve your specific skills that you're deficient on. Simulation-based training, which is slightly already kind of integrated into surgical training. However, virtual reality hasn't really come into the forefront here. And that's kind of a different way of hands-on training that we could integrate. There's predictive modeling, too, that the AI software can use to help evaluate and identify potential complications, especially in case preparation and case presentation. And then augmented reality is one of the ones that we can use in real time in the operating room, which is being looked at here in different specialties. It's performed with a head-mounted device that maps preoperative imaging on the patient, and it's been used in certain ortho specialties and things like that to overlay your imaging to the patient. So what are some barriers to AI? I think limited data and a limited availability of large and high-quality data limits our ability to create algorithms that are applicable to a wide range of patients. Data sets may not be representative of all racial, ethnic, sex, and other demographic differences that could lead to biases within the algorithm without us knowing. Another big thing is the black box effect, which is the inability of the end user to understand how we got to this decision and be able to replicate it. There are different softwares that are coming out now, like explainable AI, that improve and help with the transparency of those hidden layers in the neural networks and the machine learning. Who's the responsible party if an outcome is negative? I think that's something that facilities are going to have to look at if they're bringing AI into the clinical setting. And is patient data protected in large sets, in data sets? We know that we put this data into a computer system that's HIPAA compliant, but does that data go anywhere else in the system? And how do we make sure that that doesn't happen, so protected health information is not spread throughout the system. I think those are things that we still have to look at and make sure are set before we start integrating it fully into our system. So is AI overhyped or undervalued? I think evidence is still emerging, but generative AI tools in clinics have the potential to improve efficiency and reduce clinician burnout, especially given staff messages and patient messages that we get kind of around the clock now. It has promising adjuncts to help improve patient care and time to treatment. It can individualize care based on risk calculators that we don't currently already have. And I think it's a way to progress surgical education. Okay. Any questions? Yeah.
Interesting talk. My question is this, I think I understand how open evidence basically works. To me, it's a little bit of an upgrade of a Google search. But, most of our patients are not a 73-year-old with 5.7 centimeter aneurysm. They've got a creatinine of 1.9, they've got moderate COPD, they've had a recent stroke in the past year. Those are the patients where they really have complexity that we need intelligence to help us understand what's the right thing to do, analyzing all the potential statistical odds of each one of those factors affecting their outcome. I understand where this is the beginning, but there's a lot farther we have to go before I think it really starts to help my day.
Yeah, no, I definitely agree with that. And yeah, I mean, what I asked was like kind of the most basic question, and you kind of know the answer you're going to get from that. But yeah, I definitely agree. I think there's still a lot of work that of course has to be done, and these models seem to be getting better, year by year, and even with ChatGPT over the last several years, like the improvements. So hopefully with open evidence, it'll do the same of just being able to make more nuanced decisions and truthful ones and things like that. But yeah, it is difficult, especially when, for us, there are so many factors that go into making these decisions, like you said, like their creatinine or their comorbidities and things like that. So, it's not perfect, but it can help in, definitely certain situations. But yeah, I'd say situation dependent.
I mean, I foresee the day where it's so embedded in something like Epic, where before we've even seen the patient, it basically tells me, here's what you should do with this patient today.
Yeah.
Here's the adjustments in the meds, here's everything. And you write the note, all I need to do is review it, click it, and I'm done.
That'd be pretty
The
nice.
orders are done, everything's done.
Yeah.
I think the data sets are really important too, and that's where we get all that information. I think having a standardized data set, which is
Kind of the direction that they're going into for all the data that they're inputting into these algorithms.
I think that's gonna help with these more complex patients. We're not there yet, like Dr. Schmidt said, but I think if we can identify in the data set what the issue is and what the discrepancy is in the ability for the algorithm to make that decision, I think that'll be a key factor in figuring out exactly what to do with these complex patients.
You mentioned somewhere along the lines that the ability of some of these models to create their own evidence and to generate their own answers or their own supporting documentation. I'm curious to know, how do you think that's, and the ability of providers to influence that choice is going to shape the usefulness of this going forward?
Yeah, I think, I don't know what impact the providers themselves have on, I guess, shaping it per se, but
Well,
is-
at some levels, grumpy old man is not gonna use it because he's afraid there's gonna be one embedded
yeah.
faked number somewhere in there, but there's obviously a spectrum of
Yeah.
how does, and are we ever gonna have control over some of that, or?
I know, I guess that's a difficult question.
Okay.
Hopefully, I guess I don't know, I don't know, of course, everything that goes into them,
Sure.
actually making these models and everything. I think, over time, it can sometimes be easier to identify when things just sound off with these models, or even sometimes, I've been on ChatGPT and asked a question and then I go to look up the article and it doesn't even exist. So, and it's a pretty quick, you pretty quickly find out, you're like, oh, this isn't actually a real article. So I think right now, at least, it's just important to still check your sources and, what, if something doesn't sound that reasonable, it's probably not.
Right, but
Um,
as the models get better, they'll be better at hiding it.
Yeah, that's true too. So I guess it's like a double-edged sword because they're gonna get smarter and give us better information, but yeah, at the same time, they can also get better at lying. So yeah, I'm not sure how that'll turn out, and it could be a big problem. Especially, yeah, as Dr. Patel mentioned, like, you know, who's gonna be responsible if someone has a negative outcome from, you know, something that AI tells us. So yeah, it's definitely something to consider and definitely just like encourage people to be careful, especially if they're using these in relation to their patients. Cause you know, I think right now it would definitely just fall on us of if we misinform people or have bad information from one of these kind of chatbots, then, you know, we're like perpetuating that. But, so yeah, we'll see what happens. Thank you, everybody, for coming.